Perfect. Well, welcome everyone. During the presentation, feel free to come off mute if you have any questions, submit questions in the chat. We will have people monitoring that. And then we will be uploading the slides to the TSAC page afterwards. So take a look at that. And then if you're listening by phone, press *6 to unmute your line or *9 to raise your hand. And then if you want to use closed captioning, you definitely can by clicking the CC icon at the bottom of the screen. And then if you need any accommodations for future meetings, always reach out to John R. Berry. You can email him directly, and then he will be able to make those accommodations for you. So just some housekeeping. And then our mission at HICPUF is improving healthcare equity, access, and outcomes for the people we serve, while saving Coloradans money on healthcare and driving value for Colorado. The Department of HICPUF, Healthcare Policy and Financing, administers Health First Colorado, Colorado's Medicaid program, Child Health Plan Plus, CHP Plus, and other healthcare programs for Coloradans who qualify. All right, so here's our agenda for today. We will first start off by hearing from a guest speaker, Sherry, who is from People Care Health Services, which represents a large portion of Colorado. She will be speaking about in-home support services. So we're definitely looking forward to that. And then after that, we'll have some program updates from members of our SID team within HICPUF. We'll start with home maintenance allowance, and that will be presented by Sarah and Karina Barr. And then we'll have rapid reintegration work group information that Sarah will let us know about. And then we'll have some transition services updates by Matt. And then last but not least, a job form update by Susie, and then followed by open discussion. So now we will go ahead and send it over to Sherry to talk about IHSS. Hey, Sherry.
Thank you so much for having me today. Looking forward to, you had requested this topic just from an agency's perspective and kind of what we see and the process. And so as I go through these slides, hopefully it can help answer some questions. Feel free to ask other questions in the chat, and hopefully you can help me with that. Next slide, please. Perfect. So I know that you had Consumer Direct came and spoke to this group back in February, and they probably went over a little bit more deep into the rules and things like that. But I just wanted to give a reminder overview of IHSS. So IHSS, and some of you are probably familiar. I recognize some of the names on this screen. So I think a lot of you we've been sitting in the same meetings lately, is really the consumer directed portion of consumer direction that HICPUF offers that is the opposite side of CDOS. I like to think of it as two different sides of the same coin. Aaron Thatcher and I have talked about this before, and it's really a great way to think about it because CDOS, the consumer directs it, IHSS, the consumer directs it, but they have the support of an agency. And this is great for anyone who needs that additional support, whether it's the financial piece where they have trouble managing that with CDOS, or the acuity is such that having an RN available and skilled assessment needs available is certainly in their best interest. So this is all through the Health First Colorado, the Medicaid program. They need to qualify for the home and community-based service waivers, of which IHSS is an approved delivery option. A lot of you who sit on the same meetings that I have lately realize that as of 7/1 of this year, some of that's going to be changing with Community First Choice, and IHSS will be under that umbrella more so than what it is currently. But I decided to talk about currently. HICPUF is certainly more well-versed in what's coming and what that all looks like, but just wanted to talk about that. So the member has to have a demonstrated need for personal care, homemaking, or health maintenance. Those are those skilled tasks. Members can be in unstable health, but they have to be able to direct their own care or assign an authorized representative, or if one is required. One of the requirements before IHSS services can start is the physician, their primary care physician, usually fills out what's called a physician attestation, which says that that physician or provider says that they either can direct their own care, that they have the cognitive and ability to do that, or they need somebody else to. So next slide, please. All right, so currently IHSS is available in the following HCBS waivers. So the Children's Home and Community-Based Services, a CHCBS waiver, Complementary and Integrative Health, the CIH waiver, and the Elderly, Blind, and Disabled, or EBD waiver. Next slide, please. So how to start? We get this question a lot. How does it start? Sometimes we'll even have Medicaid members call our agency and we have to redirect them. So they have to be referred by a case manager, who then sends the referral to us as an agency for IHSS services. Sometimes, depending on the member's needs, it might appear like they don't need any skilled services, and we work collaboratively with the case manager to make sure that if they do need skilled tasks, maybe the member forgot to tell the case manager about something. It happens all the time where, oh yeah, I do need help with my medications or things like that. So it's really a collaborative effort with the case manager and the agency and the member to come up with a plan of care that meets their needs. Next slide, please. So here's the process from referral to start of services from the agency perspective. So here's what happens kind of from beginning to end, what we see. So the IHSS agency receives a referral from the case management agency. Then we go and do, and I can't speak for other agencies, but our agency, and as Samantha said, we serve most of Colorado. We serve 46 counties, pretty much all the rural counties. The Denver area and some of the north is served by our sister agency, Pasco, but we go anywhere. I've always been amazed that my agency is willing to send me, an RN, to the far corners of the state to meet with a member, to help develop a care plan, to do skills validations if needed with the caregivers, that sort of thing. So, but we do, as an agency, we do all of our intake assessments in person. We want to see the home environment for safety. We want to really be able to do a walkthrough with them and be able to get eyes on and see what does it, if they say that their transfer, that they're unsteady in their transfer, I like to ask them, can you show me? And then we talk through it. And maybe there's some education that needs to happen around that task. So then we determine with them their care needs. When we get that referral from the case manager, they usually send what's called a calculator. And I know that that's part of that is changing in July, but it really has, the case manager's already done their assessment and helped with the member determine what they need. Then we go do it in person and we go over that with them to see if that's accurate or if things have changed. Perhaps that original case manager had done that assessment with that member maybe a month ago, and in the meantime, they've been in the hospital or maybe their needs have changed. So we really want to try to do an updated assessment and make sure that we're all on the same page. What we try to do is any identified caregiver, and really our initial phone call to the member is going to see if they have any relatives they want to come on as a caregiver, if they have friends, neighbors. We have a list of questions that we ask because sometimes they think they don't have anybody, but when asking something as simple of, well, you know, does anybody ever help take you to the store or help pick up prescriptions for you? That might bring somebody to mind that could help. We all know that staffing throughout the state and frankly throughout the nation right now is difficult to find caregivers, people that are willing to go in the home and help. And so we try to identify anybody that they might have. And we try to onboard them at the same time as the assessment is working its way through the system. So for IHSS, many of you already know this, any skill tasks, those health maintenance tasks have to be evaluated and approved by a third-party vendor, which is currently Telegen. And so it has to go through a whole process. So the agency completes their assessment, sends it to the case manager, who sends all the documentation to that third party to get evaluated and approved. And sometimes they request more information. And we try really hard as an agency to collaborate with the case managers. If they need help tracking down documentation or doing something, we try to help them with that as much as we can, because I do know that case managers are overloaded and they have all these changes coming, and we want to be a partner with them and help as best we can. Those health maintenance activities, any of those skilled tasks, they require by rule a validation of those caregiver skills. And this has to be completed by the agency RN. Either we do it either in person or on video, depending on what the skill is and the task and what's appropriate. And then once that prior authorized review or PAR is received from the case manager and the caregiver's fully onboarded, or if they don't have anybody and they want a non-relative caregiver, we identify them, make sure they're ready, do that skills validation. Then we can do a specific schedule built for that member and start services once that PAR is received and we have all those pieces in place. Next slide, please. So a lot of clients, what they'll tell us what they really like about IHSS is because it waives the Nurse Practice Act and allowed those skill tasks that we talked about. Members can have friends, family, outside caregivers, provide the skilled care under the supervision and validation of an agency RN. Next slide, please. So a lot of times we get this question too. What kinds of things are allowed on IHSS? I've been with People Care for 10 years. I've been through multiple Department of Health surveys for our agency, successful ones. And I had met with surveyors and they've quizzed me or grilled me, however you want to look at it, on skill tasks and what's appropriate and what's allowed. And really what's beautiful about IHSS, and one of the reasons I love it, and I've done this for so long, is that all these kinds of things can be allowed if appropriate. Wound care, feeding tubes, diabetic care, blood sugar monitoring, insulin injections, vital signs. One of the things with vital signs and things like that, anything on a care plan that we put has to be not have to require any amount of clinical judgment. So in other words, if we have somebody checking a blood pressure, those parameters of what's acceptable and what's normal for that client will be on the care plan. It won't be like, well, I don't know if it's high or low and what I should do about it. It'll be very clearly documented what those parameters are and what to do if they're outside of the parameters. So again, same thing with blood sugars. I've had discussions over the years about, we have some diabetics that are on sliding scale insulin. And is there clinical judgment in sliding scale insulin? Well, no, it's really a math problem. If their blood sugar is 235, then they get so much insulin based upon that. It's not a clinical judgment, it's a math problem. So it's really, you have to look at the big picture and what's appropriate, things like that. We can do medication setup and administration, skilled transfers, including lifts, infusions, injections, skilled bathing. We can implement prescribed exercises of PT, OT, skilled accompaniment, skilled skincare, oxygen care, nebulizer treatments. All of those kinds of things are all allowed under the right circumstances and with the right skill set of a caregiver. Next slide, please. Another question we get is, what are the limits of IHSS? If you read the rules, there's no specific limit of what's allowed. There are skilled task definitions. So in order for it to be health maintenance, it has to meet those task definitions and be applicable. It's really up to the discretion of the case manager and the agency RN to decide what's appropriate and safe in the given situation and home environment. Like I said, when we do an intake assessment, we're doing a home assessment. We do a safety walkthrough, making sure that it's appropriate and safe. We'll maybe make suggestions. Some of our elderly clients, if they've got a lot of rugs in the home, I might say, until you get stronger, maybe we should just roll them up. They're beautiful, but let's just roll them up and put them aside so we don't create a tripping hazard. Or if the home environment, people get to choose how they'd like to live, but it may not be appropriate for us to be performing wound care where we need to have a clean environment, or IVs and things where we're concerned with sanitary conditions and things like that. So that's really an open discussion that we have with the member and with case manager to come to a good decision of what's appropriate. Next slide, please. So here's just a couple of examples I wanted to share with you of real members and what a difference we can make and what this might look like. This particular client, DD, had a lot of falls at home. He was really ill. He was seeing home health. So I work for a home care agency. We're Class B for IHSS. Home health is more of a Class A, where they've got skilled nurses actually coming in to do the care, or CNAs. He had home health coming in for a post-hospitalization follow-up. He had a new I think G-tube and some IV infusions and things like that. So they were helping follow up with that. They really wanted him to go to a SNF, and he didn't want to. And I know that this meeting and this group is all about it, trying to keep people at home if they want to be and if it's safe, and to prevent the institutionalization of people that don't want to be. He was tearful and said, I really want to stay home. And I said, okay, let's figure out a way together and come up with a plan so you can stay home if at all possible. So I actually was the one who did this. I went and did an in-home visit way out in Springfield. I don't know if any of you know where Springfield is. It's in Baca County, the southeastern corner of the state, not much out there. And did an in-home visit with him, came up with a plan between himself, myself, and the home health agency of how to keep him safely at home. And he was able to compromise on a few things that they were concerned about, some things I was concerned about, and we were able to keep him home. So that's, to me, is a huge success story. It was able to keep him where he wanted to be in a safe way, together. I know also one of the things that we find, especially in some of our rural communities, is home health agencies are struggling to find staff. And maybe they don't have a skilled nurse available, but that client or that member needs skilled tasks. I want to challenge everybody who's here today to think about maybe IHSS would be an option for them. It's not always appropriate, but I'm working with some case managers all over the state to try to bridge the gap of a lack of staff, to see if it's appropriate. So we're willing as an agency to come out. I personally have been out and would be happy to do that to help evaluate. I can come with a case manager or, pretty much anything to see what's appropriate and could this be an option for them to bridge this gap. The other thing, I know in our last meeting with this group last month, there was voiced concerns about waiting for PARs and how it's difficult. We're somebody wants to discharge home out of a SNF or a facility, and we're waiting on a PAR. One of the things that we've done successfully as an agency is we'll go, once we receive that referral, we'll go and do our original intake assessment in the facility with the member, identify caregivers, and then send that assessment to the case manager so that that PAR can be percolating in the various venues it needs to go through Telegen, all of that, so that perhaps by the time that that member is ready for discharge, we already have a PAR in place, we have caregivers onboarded, they're trained and ready to go, and then we'll go do an in-home assessment as well, just to check that home safety that I talked about earlier. And that's also a great way to help make this happen faster, if at all possible. And we've been very successful doing that. Next slide, please. And then I have one more client I want to talk about. This is a pediatric client. And this is how the children's HCBS can make a huge difference. So this little girl was born with a rare genetic disorder. She wasn't diagnosed till she was 2 years old and had to have, it was very rare. There's like 1 in 100 in the whole world. And she had to have really aggressive therapies. So in order to have a chance to walk, eat, and communicate, her mom was actually an RN who decided to stay at home and be her full-time caregiver, so that she could implement these aggressive therapies. And when I say aggressive, it just means a huge amount of time. When they weren't at therapy, they were practicing and doing therapeutic things, like 50, 60 hours a week. So very, very much, very intensive. And one of the things, this little girl is now 9 years old, and most children with this disability, they're in a wheelchair with a feeding tube. And this little girl is walking and eating and using a talking device. And the mom has really credited that she was able to be faithful and do these consistent therapies, and be at home with her. And that's what made the difference. She has people ask her that have the same diagnosis, how did you do this? And that's what she credits. So those are a couple of examples of how we can really make a difference and work together and partner together. Next slide. Any questions?
Thank you so much, Sherry, for that presentation. Definitely appreciate it. And I love that last story, just to let us know what's possible and how to improve the quality of life for some of these patients and members. So love it. And then I'm monitoring the chat. I don't see any questions right now, but we'll definitely pause for anyone to come off mute. Oh, Jen, I see your hand raised. Go for it.
Yeah, thank you. Okay, I'm in a situation right now where I use a caregiver, but they're leaving, and I'm having trouble finding a new caregiver. And my question is, I know we always say case managers are overloaded, but I kind of feel like really they didn't do any of the stuff that was in your slides.
So,
And I'm wondering what they actually do, and am I like wrong? Like educate me.
well, I think it depends on like what program you're on and if you're on one of the waivers. And I'm not familiar with your circumstances, but I know case managers, they're like the gatekeeper. They're looking at you as an individual member and what your needs are and working with you to help you um, get your needs met. And so if caregivers are an issue, I don't know if you're on CDOS or if you're on your own where you find your own
I am
caregivers.
IHSS.
You are, okay. So your agency should be helping with that. Find a caregiver, and that's the beauty of trying to work with an agency is they should have that. And I would have the conversation with your case manager and just talk about what are my options. If the agency can't, perhaps you need to see what other options you have.
Okay, thank you.
You're welcome. Thank you, Samantha.
Thank you, Sherry, so much. We appreciate it. And then if there's any follow-up questions, I'll definitely forward them to you. Appreciate your time. All right, everyone, we will go ahead and jump into our program updates for April 2025. So we're going to actually start with home maintenance allowance with Sarah and Karina. If you guys are available to hop off mute.
Hello. So funny that she was just talking about IHSS and health maintenance activities, and now we have, which was HMA, and now we have home maintenance allowance, which is also HMA. So sorry for the confusion. Of course, we like to do that. But I'll go ahead and we wanted to go ahead and kind of give an overview on what home maintenance allowance is, and then also show you where you can find this information at. So we just noticed that it kind of stated in the DOJ agreement that there wasn't a lot of information that was available in regards to home maintenance allowance. And so we wanted to make sure we provide information on our website and also regular trainings to case managers, transition coordinators, nursing facilities, to make sure that they are receiving the information to pass it along to individuals that are going into the nursing facility. So what home maintenance allowance is, it's a benefit for members that are entering a nursing facility that think they will be transitioning back out within 6 months or less and do not have family or anybody to help them maintain their housing situation. So this is to help them stay in the current housing situation that they have. And it's based off of home expenses such as mortgage, rent or lease, taxes, utilities. So this is to supplement them while they're in the nursing facility. Go ahead to the next slide. So where to start with this is the first thing would be the member would need to get a physician statement confirming that they'll be returning back within 6 months to the nursing facility. And this is a statement that would need to be signed by their physician. And also then it's usually either sent in to the county by either the hospital that is turning in the 5615, or it would be the nursing facility that would be sending this in also. So it is calculated on that 5615 to kind of see what they would be eligible for. Let me see here. Also, you'll see that there is a quick reference that we created, and it's under the general resources. And the physician statement is under the form section in the transition services resources page. So I will go ahead and drop that link into the chat so you'll know where you can find that. And then you can go to the next page, and then they'll be able to go ahead and see what those two forms look like, if you don't mind. So you'll see on the left-hand side is the physician statement. And then on the right-hand side, it kind of just goes over what I just explained, the definition, who is eligible, where to start. And then if you have any other questions, any other resources to file a complaint, to contact us, then that information is also on this quick reference. And I think then I have it open for any questions on the home maintenance allowance. No questions? Then I'll go ahead and I'll jump into rapid reintegration in the rule revision work group. And this is actually the purpose of this rule revision work group is for case managers, transition coordinators, anyone that's interested in collaborating with the department to add and change the regulations or the verbiage for rapid reintegration. So I will be, or it will be posted, the rule for rapid reintegration will be posted onto the website. And that will be coming up here later on this month. And then you can go to the next, there we go. And then, you can go to the next slide, please. There you go. We're just going to host 2 meetings in May, one on May 7th at 1 o'clock and one on May 15th at 11 o'clock. If you're interested in providing any feedback, please contact me. You'll see my emails there, and I can also drop that into the chat. Or you can email me directly, or put it on your email and your name in the chat, and I'll go ahead and take down your information. And we're just trying to, again, get that feedback from anyone that has any suggestions, or if anything doesn't sound clear, we'll make sure we go through that and have a couple of these meetings to talk about rapid reintegration. So I think that was all that I had. And I'm not sure who it goes to next.
Sorry, I don't know why I put your name on this slide. I just thought you were doing all the sections, Sarah. That should be Matt's name.
No worries. If anyone has any questions, I'll make sure I add my email to the chat, or you can directly email me or put your information if you're interested in attending one of the rapid reintegrations rule work group. Let me know. Thanks, Sammy.
Cool. Thank you, Sarah. Definitely appreciate it. And then Matt, whenever you're ready.
Hi, thank you. Are you able to hear me? My internet is terrible right now, so I'm off camera. Can you hear me? Okay, perfect. Then can we go to the next slide? I just have a couple of updates for everyone today. First and foremost, I think that some of you may be aware, but if not, Nora Bray, who has been our longtime transitions administrator, hired as of is enjoying a much deserved retirement and hopefully on her way to relaxing. So I wanted to just let people know that if they or anyone that you know are interested in the position, that position is posted on our HCPF Jobs website. It'll be posted through midnight of April 8th, which I believe is next Tuesday. And then my hope is in scheduling interviews towards the end of April so that ideally we can get somebody on board as soon as possible. If you do ever have an opportunity to talk with Nora, you've worked with her, she's been a real critical part of this program for a long time, and is really a lot of our success is due to her. So she will be very impossible to replace, but we are looking forward to sort of the next steps, next chapter. I will be providing a lot of the program oversight in the meantime. So if you are working on a program issue, if it's member related, please use our escalations email. If it is program related, please direct those directly to me. And then I just wanted to also make people aware that we did conduct our Money Follows the Person services and provider training on March 19th. So that recording will be posted onto our Money Follows the Person website shortly. It's roughly an hour and a half. If you're interested in watching, the training would be relevant if you are a transition coordination agency or somebody like a case management agency that's directly involved. It provides an overview of the more technical aspects of the Money Follows the Person services and provider requirements. So I would encourage you to keep your eyes out for that. And then we will be forthcoming with more information as we have it as far as implementation. We are still targeting May and working to establish a more confident date. And so we'll be sharing that information with everybody as soon as we have it. And I think that's it for me, Sammy.
Perfect. Thank you, Matt. Definitely appreciate it. And then we'll pause for questions real fast. Awesome. I'm not hearing any, so we will go ahead and move on to Susie to talk about job form.
Hi, everybody. This is Susie Bachler. I'm an Enrich coordinator at HIPHUB, and this is going to be very quick. Sammy, if you could just flip to the next slide. We're going to ask you all to help us remind people about our new job form process to make referrals. So that form can be used by Medicaid members, their family, their any unpaid supports. It can be used by you if you're in a facility doing transition work with someone else and you happen to talk to someone else who's interested in it. Please use that form. It helps us make sure that we have that data in real time and that people don't get lost, you know, in the system, so to speak. So I'm going to pop that link in there for you so you can always be sure to have that saved on your computer and you can share it with your contacts. And I'm also going to pop my email in the chat. So if you have any other questions whatsoever, I'm always happy to chat with you. Does anybody have any questions? And just as a reminder, we want to make sure that they are using that as opposed to just emailing someone directly, you know, either on our team or a transition coordination agency or an options counseling agency. Just make sure to help us educate everyone that is, you know, a contact of yours to use the job form. Thanks, everybody. I don't see any questions, but I'll pop my email in the chat. Thanks again. Thanks, Sammy.
Thanks, Susie. We'll pause real quick to see if there's anything in the chat. I'm not seeing anything. Perfect. You guys are an awesome group. And then this is just time for our open forum to see if you guys had any additional questions. If you had any suggestions for future topics that you would like to see, definitely feel free to pop that in the chat and we will be monitoring that. If there's any additional trainings regarding programs you would like to see, such as CFC or anything else transitions related, let us know. We can go ahead and get that scheduled for future months. Or if you had any other issues you wanted to bring up, definitely feel free to write that in the chat or come off mute.
Hi, my name is Estelle, and I was wondering, is there a report on the number of individuals that are transitioning out of nursing facilities? Is that being housed anywhere?
Yeah, I can take that question. So the department has historically, beginning in 2019, completed a legislative report each year where we identified the number of members who received options counseling, the number of people who received transition coordination or support, and also those who have actually transitioned. That is no longer a report that is required by our legislator. So we're currently looking at how we can provide that information in an ongoing way. We've had conversations about using this forum on a semi-annual basis to provide an overview so that we can share some of that information here. But that I would say that there's more to come. It is definitely something that's been raised and we would like to be able to support, and we're sort of in the process of figuring out the best way to make that happen.
Thank you.
Thank you, Matt. Definitely appreciate it. And then there was a question that Delane asked in the chat: is the job form used only for PACE? Good question. Definitely glad that you brought this up. So the job form is used for anyone who's interested in starting or getting information about transitions into the community who are currently in a skilled nursing facility. So anyone who is interested in learning more about PACE or any other HCBS, home and community-based service programs, LTSS, long-term services and supports, benefits through Medicaid, you would just submit the job form, and then that will go to a local contact agency, and then they'll meet with the member in their natural supports one-on-one to talk about any questions that the member has, and connect them with services as needed. So good question. So no, it's not just for PACE, but it can be for PACE, yes. Hopefully that answered your question. And then anyone, feel free to answer or put any other questions in the chat, raise your hand, come off mute, whatever is easiest for you guys. Perfect. I'm not hearing anything. So we can go ahead and close this meeting early. Definitely appreciate your time, appreciate your feedback and questions. And then in the meantime, if you guys have any additional questions, you can always reach out to Matt, the Access Unit Manager, or Chanel, the Inreach Unit Manager, to talk about any of those programs. They're a good contact. And then you can also reach out to the presenters directly if you have any questions. And you definitely know how to get in touch with us, which is awesome. Any questions are welcome, but thank you so much for coming and we appreciate your time. Have a good afternoon.